Hello, everyone, and welcome to the Melanin Initiative. Here at the Melanin Initiative, we simplify medical information into language you can understand. We create a safe space for you to ask your questions and share our nursing perspective. If you're new here, once again, welcome to the Melanin Initiative. I'm Geraldine, and I co host the Melanin Initiative along with Alicia and Kimberly. We're a health literacy podcast. When we say health literacy, we're talking about your ability to obtain information, to understand that information, and to use that information to manage your health and advocate for others. Our mission is twofold. To simplify our complex health information so you can feel empowered to ask your questions, educated on how to manage your health, and confident to navigate the healthcare system. And our other mission is to elevate the expertise of nurses, spotlight the diverse career opportunities within the healthcare industry, and inform our peers how to leverage their expertise as clinicians and entrepreneurs. If you haven't already, subscribe so you can be notified when we release a new episode. Thumbs up the video, leave a comment, and share the show with your friends. This shows the algorithm that this show is important so that when people like you look for information like this, will show up higher in your search results. And as a reminder, this show is for educational purposes only. The opinions expressed here are our opinions alone. They are not a representation of any of our affiliations. If you're experiencing a medical emergency, you should seek medical attention and medical guidance from your healthcare provider. If you're having a physical emergency, you can call 911. And if you're having a mental health emergency, you can call 988 or text 741-741. So we're going to get started. Today's episode is all about UTIs or urinary tract infections.
Thank you, Geraldine. This is a really popular topic. We see it all the time in every healthcare setting, whether it's the hospital, outpatient, long-term care. You've heard of it. It's not a new word for you, but perhaps there's some confusion, misconceptions, and some things that we'd like to address in this topic. I've been personally wanting to do this topic since the beginning of the show, so I'm super excited. We wore yellow to commemorate the topic, and so let's get into it because we have a lot to cover. Let's start off with our favorite thing, and that is getting into the definition. So a urinary tract infection is an infection that can occur anywhere in the urinary system. This includes the bladder, where infections are the most common, and we call these cystitis. UTIs can also affect the kidneys, although less common is more serious, and we call that pyelonephritis or pyelo. There's also bacteriuria, which means you have bacteria present in the urine, but without symptoms, and asymptomatic bacteria, which involves high levels of bacteria without causing any noticeable symptoms. When symptoms like painful urination, frequent urination, and constant urge, so you might have some of these symptoms: painful urination, frequent urination, and the constant urge to go. On the other hand, if you have a kidney infection like pyelo, you might have pain in your back, on your side, which we refer to as flank pain, fever, or nausea. And that could indicate that the infection has moved up from the bladder into the kidneys, which we're going to show our picture of the kidney in just a second to make this a little bit easier. We have what we call uncomplicated and complicated urinary tract infections. Uncomplicated UTIs occur in the healthy urinary tract and typically in low-risk individuals. Complicated UTIs, on the other hand, happen in cases where the anatomy or something about the function is abnormal. We see this in men, pregnant people, children, and in patients in healthcare settings like the hospital or long-term care also fall in this category, and those with urinary catheters. What about urosepsis? Well, you may have heard this term if you've ever been in the hospital. It's a serious condition where you have UTI and that leads to sepsis or an infection that affects your whole body, and it can be life-threatening. We've actually covered sepsis in great detail on another episode with TMI alum, Dr. Farah Laurent. We will put that link in the description box so you can check that out and learn more about sepsis. Right now, our producer, Angie, is putting up an image on the screen so that you can see the anatomy. We're going to show the anatomy of the female and male body to make this a little bit easier for you to understand. So Angie's going to throw that up, and I'm going to throw it to Alicia.
Thanks, Kimberly. So before we move on, let's touch on why UTIs are such a widespread issue. Did you know that urinary tract infections are the most common bacterial infections healthcare professionals encounter? Among women, the lifetime risk of developing a UTI is as high as 40% to 50%, and nearly half of these individuals may experience recurring infections. Globally, the incidence of UTIs varies. The African region has the highest reported rates, while the Western Pacific region reports the lowest. And while UTIs are most often treated in outpatient settings, they are the leading cause of hospital-acquired infections among especially catheter-associated UTIs, which account for up to 67% of those hospital-acquired UTIs. So all my healthcare folks out there, we always say, get those catheters out and let's not put them in if they're not necessary.
Mm-hmm.
So the risk associated with UTIs extend beyond the infection itself. Frequent recurrences, kidney damage, sepsis, and even preterm births are possible complications, not to mention the indirect effects, such as the emergence of antibiotic resistance and the societal burden of healthcare costs and time away from work. So you may be asking yourself, who's at risk for UTIs? Well, risk factors can vary, but include a history of previous UTIs, changes in vaginal flora due to menopause or spermicides, pregnancy and advanced age, structural problems in the urinary tract, such as an enlarged prostate or kidney stones, poor hygiene, a neurogenic bladder, which really means signal from your brain to your bladder is impaired. An example of that would be someone who has perhaps experienced a stroke, or even urinary tract obstruction. For women, UTIs are especially common due to their anatomy. A shorter urethra and proximity to the rectum make it easier for bacteria to enter the urinary tract, which is why we always tell folks you need to wipe from front to back. Sexual activity, contraceptive methods like spermicidal jellies, and conditions like estrogen deficiency or bladder prolapse further increase the risk. For men, risk factors include insertive anal intercourse, prostate enlargement, and being uncircumcised.
Again, Angie is helping us out right now by throwing up some images of the male anatomy. Before I jump into that, I just want to cover two vocabulary words. So you mentioned flora, which some of you might be familiar with because everyone's really talking about probiotic. I feel like we talked about it. Prebiotics. And so today we're talking about the presence of bacteria that your body can't heal on its own. But we have bacteria that's already present, and it's either not harming us or it's actually doing us a great service. And we tend to call that flora. So I just wanted to cover that one.
All right, Geraldine, passing it over to you.
All right. So now let's discuss what causes UTIs. So the most common culprit is E. coli. It is responsible for 70% of UTIs in the general population. Other bacteria like Klebsiella pneumoniae and Enterococcus also play a role and can cause UTIs as well. Interestingly, the pathway of infection often begins with the bacteria traveling from the urethra into the bladder. Activities like sexual intercourse or the use of certain contraceptives can facilitate this process. Sometimes infections can spread through the bloodstream, leading to abscesses in the kidney, and this is more common with bacteria like Staphylococcus aureus or Salmonella, which are also organisms that can be found in UTIs and urinary tract infections. The symptoms of UTIs typically include pain or burning while urinating, frequent urges to go, and sometimes fever, nausea, or back pain, or that flank pain that Kimberly mentioned earlier. For younger children, the signs may not be as clear, but a fever could be an indicator of a UTI in infants and toddlers. Younger children may not be able to tell you about the UTI symptoms that they are having, so it's very important to kind of pay attention to those signs and symptoms, such as the fever, because they might not be able to tell you what's going on. Other symptoms include pressure or cramping in the groin or lower part of the abdomen, fever, chills, and then poor diagnostic indicators include vaginal discharge or vaginal irritation. Now, when should you seek medical treatment? If you or your child experience any of these symptoms, or if your child is younger than 3 months old with a fever of 100.4 degrees Fahrenheit or higher, it's time to see a healthcare professional.
Thank you, Geraldine. I do want to point, since we throw up our graphics of the anatomy, I think it's easy to see that with the female body, that external entrance into the body is so much shorter to get to the bladder than in the male anatomy or someone who has a penis. It has to travel so much further. And so on that track, it might get stopped, and that's why we don't see it as much in men. But when we do see it, it's that much difficult to treat because of the anatomy. Same with children. So I just wanted to point that out. We are going to be, I don't even think I told the girls yet, but later this year, we're going to be rolling out our Anatomy and Physiology 101. We're going to just be delving deep into each organ system and explain it in a way to make it easy for parents to talk to their children about their body. So if you're interested in signing up for any of our organ systems, just contact us directly. We want to thank Dr. Trotter, who's already agreed to come and talk to us. She's a dermatologist, and so she's already agreed to come and talk to us about the skin, hair, and nails. So let's get into diagnosing the UTI. So if you come to see Geraldine, she's going to ask you about your symptoms, conduct a physical exam. She might order some urine tests if it sounds like it's suspicious for a urinary tract infection. And so if you think you might have a urinary tract infection, you schedule your appointment, you're on your way there, you're in the waiting room, and you need to empty your bladder, let them know at the front desk, because they might just want to go ahead and get a sample then. Otherwise, if you empty your bladder completely, you might have to drink a bottle of water and sit there. And if you're in the DMV, we are a global platform, right? We consider ourselves to be have a global audience, but we have a special heart for the DMV, DC, Maryland, Virginia. This shows a love letter to that area. And in that area, there's a lot of traffic. And so you took a long time to get there. It's going to take a long time to get to your next destination. And so we just want to avoid you having to sit in the waiting room waiting any further, or even having to come back. If my brother had a doctor's appointment, he had to literally come back another week just to do blood and urine. So we want to help save you time and the money that it takes to get there. So let them know at the front desk. They're used to it. There's usually sample cups already in the bathroom. And then they might prescribe you an antibiotic, and we'll get into more details about that as well. Our TMI pearls, we want to point out some key symptoms. Fever, having a high white blood cell count or confusion, what we call altered mental status, in combination with positive urine culture, doesn't necessarily mean that you have a UTI and that you need to have antibiotics. There are other conditions that have those same presentations. And so we just want to make sure we rule out all of those things and get you the accurate diagnosis and the right treatment. We have something called cystitis triad. Remember, cystitis is the name of bladder infection, triad meaning three symptoms at once. So if we have someone who has painful urination, reports of frequency or urgency, meaning they go very often, or they can barely make it there in time, that can indicate that they have either a kidney or a prostate infection. And that's typically unusual. We don't usually see that in people who have UTI. And then for our older adults, my favorite population, just like Geraldine mentioned with the children who might have difficulty communicating their symptoms, we see the same thing in older adults because of things like confusion, dementia, but also fatigue and weakness, and just behavioral changes that can come with age or with diagnoses that we see more commonly in our older adults. A big thing for us, especially as nurses, is prevention. We talk about it all the time. When we talk about primary care, we're talking about preventative care. And so, especially in things like urinary tract infections, which you're so familiar with, very common, we have an issue with overdiagnosing it because it is so common. Sometimes we can take for granted those symptoms and forget all the other things that also are present. And so in order to help decrease that, we want to make sure that we're only treating people who meet the clinical criteria because we want to avoid something called antibiotic resistance, which is the use of antibiotics in inappropriate situations. Other things that might have very similar symptoms are sexually transmitted infections. We've covered that already in a general overview, and we'll get into more detail in future episodes. We want to thank you because that still remains our #1 most watched episode. We're almost at, depending on when you're watching this, we might be at 2 years now. And in 2 years, it is still the #1 watched episode. That tells us something. So we're going to be bringing more information to you. Also, vaginitis, which could be infection or just an inflamed vaginal tissue, a pelvic inflammatory disease, and interstitial cystitis. Geraldine's going to get into the testing, and so let's break it down.
Yeah, so usually when patients come in, if we're talking like the outpatient setting, if they come into my clinic, usually we collect a urine sample, and we typically want what's called a clean catch urine sample. And the way that that is conducted is that we give you an antiseptic wipe. For females, you're wiping front to back to cleanse that area, just to minimize any bacteria or any bacteria that's present on your skin from getting into the sample, because we want it to be as accurate as possible. So usually this requires a urine incubated in the bladder for at least 2 hours. So like Kimberly mentioned, if you're in the waiting room and you need to go, ideally it's better to get that sample that has been sitting in your bladder. So definitely let the front desk or the provider or whoever's there know that so they can collect that sample from you. And there are two types of testing that typically is done in the outpatient setting. We can do what's called a urinalysis dipstick. So we dip the stick in the urine, and there's like little squares that we look at different things. We look to see if there's blood in the urine. We look to see if there is protein in the urine, which can indicate other things. We also check to see if there's bacteria in the urine, commonly referred to as leukocytes, as well as nitrites, which is a highly specific, that test looks for gram-negative specific bacteria. And then another test that we do, which is a little bit more sensitive, would be sending out that urine sample for what's called a urine culture. And that test is what looks it usually takes about 2 to maybe more days for them to get results. But that looks specifically at the type of bacteria, if any, that's causing the infection. So symptomatic infections usually show a specific number of bacteria in the urine. And then the test will also kind of give you a breakdown of what antibiotics should be used to treat whatever bacteria is causing the infection, if there actually is an infection.
All righty. So we have some good news, folks. Most people can be treated at home, but some people require hospitalization. So those who would require hospitalization are those that are hemodynamically unstable. So maybe your vital signs are unstable, that heart rate's too high, or that blood pressure is too low. You have a fever that's really high, that kind of instability. Or they have sepsis. You have pyelo in a pregnant or an immunocompromised patient, and someone who's immunocompromised means that they have a really hard time fighting off infection. Urinary obstruction, resistant organisms requiring IV therapy, unavailability of the oral route, so you're not able to take in those pill antibiotics, kidney or kidney abscesses, and failure of outpatient therapy. So you went to Geraldine's clinic and whatever she prescribed to you didn't work that well, so now you need to come to the hospital.
Yeah, and immunocompromised patients usually know who they are, but if you're someone who hasn't been diagnosed yet, or it's a family member and you're just not that well informed about their disease, these are people who might be like lupus patients, and so it could be the disease itself that makes them immunocompromised, like leukemia, where they have a low white count, which helps fight bacteria, or it might be on a medication, which also makes it difficult. So people who are on chemo, people who have received a transplant, and so now they take a medication we talked about that actually with in our facial transplant episode. We talked a little bit about it, and we'll talk about more in the future, but those are patients who she's referring to are immunocompromised. So let's dig deeper into the treatment and management, starting with uncomplicated cystitis, which we've mentioned is the most common. When we talk about antibiotics for treating uncomplicated cystitis, we want to keep it straightforward and effective. There are a few options for treatment that you've probably heard of. Alicia?
That's right, Kimberly. For most patients with uncomplicated cystitis, one of the first line treatments is nitrofurantoin or macrobid, which is typically 100 milligrams twice a day for 5 days. It's important to avoid this medication if there's a suspicion of early pyelo or if the patient is older than 75 years or has kidney issues. Another option is Bactrim, which is 160 milligrams / 800 milligrams, that's the dosage. Basically, one double strength tablet twice a day for 3 days. However, if resistance is known to be high in the area that you live, which means the antibiotics does not work as well as it used to, or it's not as effective, or if the patient has used it recently, we may need to consider something else.
Exactly. Those are two very common antibiotics that I prescribe for UTIs in the outpatient setting. However, another choice can be fosfomycin, which is a single 3-gram dose So this is a good option for many patients, but again, it's not recommended for people who have early pyelo or kidney problems. If these options don't work, we can also look into beta-lactam antibiotics like amoxicillin clavulanate, which is also known as Augmentin. And this is taken over 3 to 7 days, depending on the situation.
Now, when it comes to something more complicated like pyelo, which we've mentioned as a kidney infection, so this is all that prevention, right? We're going to get into prevention later, but if you do the things that we say, starting with wiping front to back, we're going to say at least 20 times in this episode, then it decreases your risk. But let's say that bacteria does enter, and we've shown you the anatomy. And so if we can prevent it from traveling so far up into the kidneys, we can prevent complications, longer antibiotics, more cost of care, more pain, more symptoms. And so if we can stop things either early on here or right here in the bladder, that's our goal. Mm-hmm. And so when it comes to uncomplicated pyelo, typically they don't require hospitalization if they're stable and not showing any signs of severe illness. For these patients, they might get something like an oral Cipro, which is 500 milligrams twice a day for up to a week. We've seen that works really well in a lot of people. But again, if the resistance to this particular drug class in your community is over 10%, we might recommend a different option.
Right, Kimberly. And for those who might need hospitalization, or if there's an issue with resistance, an antibiotic with broader coverage, like an IV antibiotics, may be needed. It's essential to keep track of your responses to treatment, and your provider will help you with that as well. For example, if there's no improvement, we need to think about complications like renal abscesses, which require more intensive treatment and possibly drainage.
And for pregnant patients, we have to be extra careful with the choice of antibiotics. Many commonly prescribed antibiotics are safe for the pregnant person and child. However, these medications include amoxicillin or cephalosporins, but other medications like fluoroquinolones or tetracyclines are contraindicated as they can affect the fetus. We also need to monitor for recurrent infections during pregnancy, which is why follow-up is extremely important.
It's also important to remember the concept of what we call antibiotic stewardship. This is a big deal in healthcare. It was my doctoral research, so I could do a whole episode on it. I'm going to save you. And so I mentioned earlier that term bacteriuria. And so, everyone's familiar with urinary tract infection. As soon as you hear that, you're automatically thinking, I need an antibiotic, right? But the truth is, some people are walking around with bacteria in their urine, in their bladder, and it's not affecting them whatsoever. And so what the data shows, which we've talked about how we get to the data, we studied thousands of people, and based on the results of most of the people in that study, we make recommendations based on what we saw work in the most people with the least side effects. So when it comes to something like antibiotic stewardship, the use of the term urinary tract infection, we're trying to encourage the use of the term bacteriuria, which is bacteria in the urine, which could be there all the time, especially in our adults who live in long-term care facilities. They become what we call colonized, which means it's just it's always there. And so what the data shows is that if you do that urine culture, it automatically leads to actions. People automatically feel like they have to respond, so they order antibiotics. And so in the data, what we've shown is if we use different terms, automatically we might start to recommend different interventions. And especially in our older adults, what we've seen is actually a lot of times if you just hydrate them, you can resolve their symptoms. Not every infection needs antibiotics. Our body can fight some things off. Some of the medications we recommend, yes, maybe you take it for a week, but all it shows is that it decreased your symptoms by 1 or 2 days. And so without taking the medications, without being exposed to those risk factors, you just wait another 1 or 2 days and then the symptoms will be gone still. And so we want to make sure that when we talk to both our clinicians and our families, that even though mom has had urinary tract infections in the past, and even though she got antibiotics and got all better every single time, that doesn't mean that in this case, at this time, that's still the right choice for mom. And so we're having this conversation with you now, and we're going to have it with you in the clinical setting, because antibiotics, while they do save lives, they're not without harm. Everything we recommend, whether it's a prescription or over the counter, comes with side effects, and antibiotics are part of that. I think we mentioned C. diff, right? C. diff is one of the most common things that we see, which is a watery diarrhea that is very infectious and contagious and typically requires you to be in the hospital. That's one of the most common things that we see. And so when we prescribe medication for a certain period of time, We need you to complete it so that that bacteria doesn't become stronger than the medicine. When the bacteria becomes stronger than the medicine, we have to find other medicines that can treat you. And as we all can attest, at some point, people who have been on so many antibiotics, whether by choice or whether by their disease, they can't even use the other ones anymore. They have to use these really high, powerful ones. And those pretty much always require you to be in the hospital with a catheter in your arm, and they're quite expensive. And at some point, the concern is that even those won't work. And so when it comes to antibiotic stewardship, we just want to make sure that we're using them appropriately at the right time for the right patient, and that we're cautious about the treatments, and that we only prescribe what is the lowest dose for the lowest amount of time that's going to be the most effective. Like I said, I can go on and on about this one.
Let me tell you, Kimberly, I had an aunt not too long ago tell me that she was experiencing an upper respiratory infection, which will be another episode of ours. And she said, oh, yeah, I had some antibiotics left over from the last time I was sick. And she started taking them again. And the nurse and me cringed. So, of course, I had to educate my family on we cannot do that. We have to take the medication as prescribed for all of the reasons that you previously mentioned. But anyway.
That's a good point. Because that's a problem. We need to have our pharmacist back on, Dr. Mark Smith, who talked to us about diabetes, right? Because this is a conversation they have all the time with patients, not taking someone else's prescription, making sure you throw them away safely. So we want to make sure that you know that your pharmacist is also a really good ally in this case to answer your questions and to address your questions. If you feel like Geraldine recommended you something and you've been taking Macrobid for the last 10 years and all of a sudden she doesn't want you to take it anymore, go talk to Mark Smith. He's going to help explain to you why she got to those decisions, and hopefully through that, you get to informed and you feel more secure and confident in the recommendations, and then you'll get the treatment that you need. But that's such a good point, and that may need to be a whole episode because people do that all the time, not just because they don't know, but also money is an issue, right?
Yeah.
I mean, that's a real thing. So good point. Thank you for bringing that up. And we love when Alicia shares her stories.
Absolutely. As nurses, it's vital that we educate our patients not only about taking their antibiotics as prescribed, but also about preventing UTIs in the first place. Simple steps like urinating after sex, staying well hydrated, and proper hygiene like wiping front to back, that's number 21 medicine, Kimberly, can make a significant difference in reducing risk.
And for those with recurrent UTIs, there are additional strategies like low dose antibiotics that are taken nightly or after sexual activity that can be an option. So it's very important to talk to your healthcare providers about that. The goal is to always prevent recurrences while minimizing risk associated with long-term antibiotic use.
You know, this is such a dining room conversation, right? Because everyone's going to tell you their favorite cranberry product as soon as they start having symptoms. I can't tell you how many calls and text messages I've gotten about cranberry. So our clinician friends will appreciate that what I'm about to say comes from the Cochrane Review. So there are different levels of studies, what we consider like high quality evidence and low quality evidence. Cochrane is at the top tier. So according to Cochrane, they found that evidence suggests that cranberry products can actually help reduce the risk of symptomatic culture verified. So when you go to the clinic and Geraldine makes you pee in the cup, and then she gets those results back, and she said it's going to tell her exactly which bacteria are present and the antibiotics that are going to be the best to address them. That's what we mean by culture verified. So in those 48 hours that it takes for the results to come back, you could go home and just be really, really hydrated, continue to wipe front and back, avoid sexual activity, wear the appropriate underwear until you get the right antibiotics. But sometimes we'll do something called empiric, right? So we'll use something that covers kind of everything broad until we get the results. And then they might call you back and say, okay, now go ahead and take this one that's the best suited for your infection. But anyway, so it's culture verified. Specifically, this includes women who have recurrent urinary tract infections, children, people who are at high risk for urinary tract infections, and certain intervention after people who have had like a lot of interventions in that body part. However, this evidence doesn't support that the use of cranberry products will work as well in our older adults, people who have bladder emptying issues, and pregnant women.
That's a great point, Kimberly. It's important to remember that cranberry products are not a one size fits all solution, but they may benefit some populations. Always consult with a healthcare provider before trying any alternative remedies, especially when dealing with something as serious as UTIs.
So, we covered a great deal today. In summary, there are various ways to manage UTIs, and the best approach depends on the type of infection and the individual patient. It's all about balancing effective treatment with minimal risk of complications and ensuring patients understand the importance of both treatment and prevention. Prevention is key. Three takeaways for today's episode. Here is number one: know when to seek care. If you experience UTI symptoms like burning during urination, frequent urges to urinate, or lower abdominal pain, as well as lower back pain, which we refer to as that flank pain, seek medical attention promptly to prevent things from progressing and becoming complicated. Number two, preventing UTIs starts with simple habits. Now, this includes staying hydrated, practicing proper hygiene, such as wiping front to back, and avoid delaying bathroom trips. So as nurses, we're guilty. When we're on the go, we're working, we tend to hold our urine, which is not a good practice. And not just nurses, our truck drivers tend to do the same thing, our teachers. So it's very, very important. Go to the bathroom, go to the restroom when you feel the urge to go. Don't wait. For those with recurrent UTIs, preventative strategies include behavioral changes as well as possible medical interventions. So always talk to your healthcare provider about your options. And then evidence-based science and staying informed. So treatment plans and prevention strategies are constantly evolving, especially with advancements in antibiotic resistance and emerging therapies. So stay informed, work closely with your healthcare provider, and advocate for evidence-based care.
Remember, everyone, you can email us your questions or show ideas to tmi.melanin@gmail.com. If you haven't already, there's still time to subscribe. Give us a thumbs up, leave a comment or two, share this information with your network so that when people like you look for information like this, will show up higher in the search results. Any information that we mentioned today will be in the description box, as well as how to connect with us on social media. At the time of this filming, we release new episodes weekly on Sundays at noon Eastern on YouTube, Facebook, and LinkedIn, thanks to Angie. And the audio drops at 5 a.m. so that our night shifter friends can be the first to get something and not the last. And maybe one day someone will play it during huddle and tell us about it. We thank you all for watching. We'll see you next time.
Bye.